Hello, the aim of this video is to give a solid introduction into ECGs. We will look at what an ECG is, the electrical conduction of the heart cycle and how this translates to the ECG trace, ECG intervals and timings, and then an overview of how the 12-lead ECG works. ECG stands for electrocardiogram. It uses surface electrodes to record the heart's electrical impulses. These electrical impulses trigger muscle contraction and therefore the pumping action of the heart. Interpreting an ECG comes with understanding how the ECG signal represents the heart's electrical and contraction cycle. So here is a summary of the electrical conduction through the heart. The impulse starts at the sinoatrial node in the right atrium. It travels across the atria, causing atrial depolarization and contraction. This forces blood from the atria into the ventricles. The impulse then reaches the atrioventricular node, which is between the atria and the ventricles, where it is then slowed down for a short period. The impulse then travels down the ventricular septum through the bundle of His. Left and right bundle branches then go to their respective ventricles, and the impulse then travels up the main ventricular masses through the Purkinje fibers. This causes the ventricles to depolarize and contract from the base upwards, forcing blood out of the heart. It is also important to mention that after depolarization and contraction, the heart muscle undergoes repolarization, which allows muscle relaxation. So now let's talk about the ECG trace. It consists of a P wave, a QRS complex, and a T wave. The P wave represents the electrical impulse travelling across the atria and therefore atrial contraction. There is then a flat or isoelectric line where the impulse is held at the atrioventricular node. The QRS complex represents the depolarization of the ventricles and therefore ventricular contraction. The first downwards deflection is the Q wave, the first upwards deflection is the R wave, and the first downwards deflection following the R wave is the S wave. In some instances, there is no Q wave before the R wave, but the complex is still termed a QRS complex. The T wave represents ventricular repolarization or relaxation. There is electrical activity of atrial repolarization, but it is lost within the QRS complex. So now we've looked at each step, there are a few important intervals to be aware of. The PR interval is from the start of the P wave to the start of the QRS complex. This is from the start of atrial contraction to the start of ventricular contraction. An important factor in this is that it can elongate or shorten depending on the activity at the sinoatrial node, represented by the length of the isoelectric region. Next is the length of the QRS complex, which is the time from the start to finish of ventricular depolarization. If the QRS complex lengthens over a certain duration, it is classed as a wide QRS complex. The QT interval is from the start of the QRS complex to the end of the T wave. This is from the onset of ventricular depolarization to the end of ventricular repolarization. So after talking about intervals, we would want to be able to accurately measure them. ECG paper is essentially graph paper, and although it can be changed, the width of a large square normally represents 200 milliseconds. The large square is then further divided into 5 smaller squares that therefore represent 40 milliseconds each. So if we were to apply this to the intervals, the PR interval is normally between 3 to 5 small squares, which is 120 to 200 milliseconds. The QRS complex has a normal duration of 3 small squares, which is 120 milliseconds. The QT interval is considered prolonged if greater than 450 milliseconds, which is roughly 11 small squares. However, the QT interval varies with heart rate and is normally corrected by the ECG machine to give the corrected QT interval, and has a normal range depending on factors such as gender. Another important aspect of ECG timing is heart rate. This can be calculated by the RR interval, which is the time between subsequent R waves, or essentially 2 heartbeats. The easiest way to calculate this is to divide 300 by the number of large squares in the RR interval to get the heart rate in beats per minute, as shown here. A normal range for the heart rate at rest is between 60 and 100 beats per minute. And knowing these rough calculations is a good starting point to quickly assess whether a heart rate is fast or slow, or tachycardic or bradycardic, to use the proper terms. You can also divide 1500 by the number of small squares in the RR interval, or if the RR interval is variable in what we call an irregular rhythm, the whole ECG strip normally represents 10 seconds, so times the total number of R waves by 6 to get a rough estimation of the heart rate. So now we're going to go through how a 12-lead ECG works, and to do this I'll introduce two main concepts. The first is that the position of the electrodes in relation to the direction of the electrical impulse within the heart dictates the direction of the ECG signal recorded. So here we have two electrodes and the impulse is running in the same direction towards the black electrode. This will cause a positive deflection to be appreciated in the black electrode. But if we swap the electrodes around, the deflection in the black electrode will be negative as the impulse is travelling away from it. If the electrodes are then placed perpendicular to the direction of the impulse, the deflection recorded in the black electrode will be isoelectric. Because of this, having electrodes in different locations can allow the same electrical signal to be viewed from different angles. So this is essentially what the 12-lead ECG does. 4 limb electrodes and 6 chest electrodes combine to make up 12 different views of the heart's electrical conductivity, which make up the 12 leads of the ECG. Because each lead has a different point of view or vector through the heart, it records the electrical impulses differently due to the reasons previously discussed. This creates an almost three-dimensional picture of the heart, and different views or leads can be utilized and compared to get different information regarding the heart's electrical conductivity and function. The easiest way to introduce that different leads look at different views of the heart is to think about the coronary artery territories. There are 3 main coronary arteries, which are the right coronary artery, the left anterior descending, and the circumflex. These supply the inferior, anterior, and lateral heart areas respectively. Any ischemic change that occurs in these areas will show up as ECG changes in particular leads that view that area of the heart. The inferior leads for the right coronary artery are 2, 3, and AVF. The anterior leads for the left anterior descending territory are V1 to V4, and the lateral leads for the circumflex artery territory are 1, AVL, V5, and V6. This is a very basic introduction, but is a good initial orientation as to where each of the 12 ECG leads are looking. So that's everything that I have to go through in this video. We have spoken about what an ECG is, how the electrical conduction of the heart translates to the ECG trace, ECG trace intervals and timings, and an introduction to how the 12-lead ECG works. This video is by no means comprehensive, but hopefully has given you a solid basis to start your journey of ECG interpretation with. Thanks for watching.